Well, good afternoon. The title of my presentation is Pelvic Congestion Syndrome, a Challenging Truth. We have decided to include the word challenging because it has always been a doubtful diagnosis entity without much acceptance within gynecological circles. I have heard them saying, Eduardo, I've never seen pelvic varices during my interventions. Okay, neither have I ever seen surgeons operating with patients standing up, I reply. So, things have changed, and now it's a hot topic and a real entity. Nothing to discuss here. It is defined as an increase of intrapelvic venous structures, both in number and caliber. These are veins of varicose morphology, tortuous, and with flow inversions. Its main symptom is the chronic pelvic pain. On the left-hand diagram, we can see the four main veins draining the uterovarian plexus, both gonadal and both hypogastric veins. On the right-hand side, we observe the physiological connections between the pelvis and the lower limb veins. In the middle, we see the most famous compressive syndromes, the nutcracker and the May-Thurner. The etiology of the PCS, or pelvic venous insufficiency, is multifactorial and include that factors such as primary valvular insufficiency of the veins or venous outflow obstruction. All of them will cause pelvic venous hypertension, leading to the formation of pelvic varices. In case of pelvic floor incompetence, we will find pelvic leaks to lower limbs. We have to bear in mind that pregnancies act as a trigger factor. Why do some of these patients complain for lumbar pain? The answer is physiopathologically logical, because most of the returning blood from the left lower limb in May-Thurner syndrome and from the left kidney in nutcracker chooses an alternative pathway, the paravertebral system, leading to a higher pressure on the spine. The presence of leaks to lower limbs from the pelvis are one of the most important causes of failure in varicose limb surgery. They are well described in the deficiency of the pelvic floor, usually increased by pregnancies, will convert these physiological connections into pathological, resulting in atypical and bulbar varices. They are well described in the literature, and we have to, its knowledge is very important for avoiding non-target embolization. We have to bear in mind four of them. The round ligament vein running through the inguinal canal, the obturator vein across the obturator hole, the pudendal vein in the pubic area, and the gluteal ischiatic area in the posterior position, usually connecting with branches of the deep femoral vein. Here we see the ischiatic axis with its typical morphology. As a challenging entity, we need an accurate multidisciplinary work protocol as teamwork. The first thing we have to do is to rule out a gynecological disease. In those patients suspected of suffering from PCS, the investigation starts with transvaginal echodoppler. If pelvic varices are seen with continuous flow on the Doppler study, and this is not modified by the Valsalva maneuver, we will carry out an abdominal transparietal echodoppler looking for a compressive syndrome. Conversely, if we find pelvic varices, we saw no flow, but this is increased by the Valsalva maneuver, the selective phlebography is considered to be the next step, as a compressive syndrome is unlikely. The chronic pelvic pain is the most common symptom. It is defined as a non-cyclic pelvic pain of more than 6 months. It usually presents as a lower back pain, heaviness in the lower pelvis, vulvar area, and upper thighs. It is typically exacerbated with menses and may be associated with dyspareunia and prolonged postcoital discomfort. As we said, we always perform a transvaginal echodoppler and transabdominal if a compressive syndrome is suspected. And focusing the phlebography study, we should always assess the pressure in the iliocaval and rhinocaval sector. Then we will check the gonadal and hypogastric veins, looking for reflux and leaks to the lower limbs. Here you can see some of the possible complications. This is our angio suite. We always use a brachial access. On the left side, we can see some of the proposed diagnostic criteria of pelvic venous insufficiency that include ectasia of the veins of more than 5 millimeters in diameter. Also, a contrast filling of venous structures across the midline. When we find reflux and insufficiency of the vein, we will inject foam distally and close the upper vein with coils. In case we find leaks, we will embolize distally with coils and inject foam and coils proximally in a sandwich technique. The May-Thurner syndrome is demonstrated if a gradient pressure in the iliocaval sector is higher than 3 mmHg. We will usually canalize both femoral veins in order to achieve an adequate position of the stent. Also, it is useful the radiopaque market catheters to measure the stent. The alternative compressive syndrome is the nutcracker syndrome. It is defined as a compression of the left renal vein, resulting in a gradient pressure higher than 3 mmHg. We also access right femoral vein in order to control the position of the stent, never protruding into the inferior vena cava. We always use high radial force stents. If we find reflux in the gonadal veins, we embolize at the same time. As material for treatment, as we said, we embolize usually with foam and large size coils. Detachable coils and plugs are welcome in the upper vein in order to avoid migration of the stent, of the coils. Also, a good option could be a glue plus lapiodol. Turning our attention to our statistical results, we carried out the procedure in 300 patients between 2009 and 2012. The average follow-up was 24 months with an average age of 41 years old. The initial technical success rate was 97%, and we found only 6 minor complications. We studied a physiopathologically anomaly, and we found that in more than 50% of the patients, we found some kind of compression. Symptoms in more than 80% of the patients, we found some kind of varicosity in the limbs or in the vulvar region. And regarding the outcome of the treatment, 90% of the patients felt total or variable relief. And pelvic leaks to lower limbs, the most common was the internal pudendum, followed by obturator, inferior gluteal, or round ligament vein. Only in 19% of the patients, we didn't find any kind of leak. And as a conclusion, we have to bear in mind that echo Doppler is a have a very high precision of more than 90%. Pelvic phlebography is the diagnostic confirmation, performing simultaneously an embolization if necessary. Pelvic venous compressions are rarely studied and undervalued. And pelvic reflux may be the cause of the genital and atypical varices as well as of the recurrent varices of lower limbs. Its treatment will be both at pelvic and lower limb level. So no more excuses.
Okay, thank you very much. Any question from the audience?